Okay, so we can go ahead and get started. So we have a 74-year-old male, retired nuclear engineer. He had had left eye blurred vision for 1 year. He had been on Pred Forte QID for about a month. Then after a week, the vision cleared and he decreased his drops to once daily. He was on another drop, which he does not remember, may have been Prolenza. And then when the patient went to see Dr. Cohen for the follow-up, patient noticed the vision was blurry. His cataract surgery was 14 months ago, and he is back up to QID drops in the left eye for the past week. Medical history, vasculopath, same with his systemic meds, and then vision in the right eye, 20/20 without correction, -1, and in the left eye is 20/63, pinholes to 20/50, -2, and pressure is normal.
This was not President Carter. Wasn't he a nuclear engineer? Yeah, Carter was a nuclear.
I didn't know.
Yeah, Carter was a nuclear.
Okay, so we have a fundus photo of the right eye. The media looks clear. Disc looks flat, sharp borders, small cup to disc. The vessels look okay with the normal limits. In the macula, there's maybe one or two lightly colored areas. One in the superior mac, one more temporally. Kind of subtle lesions, might just be some changes in the RPE. And otherwise looks pretty unremarkable.
Okay, and then we have
Some
the
temporal pallor too on the disc. Okay, so here we have the left eye. Looks like there's the media looks clear, maybe a little bit of motion artifact. The disc looks flat with sharp borders, small cup to disc, and the vessels again look fairly unremarkable. And in the macula, maybe some very subtle, lightly colored lesions right kind of off the fovea. And then that foveal reflex just looks a little bit weird.
Mhm.
So here we have the right eye, an OCT. Looks like it's a horizontal section. And then attention is just immediately drawn to the intraretinal fluid kind of in the fovea, and then a little bit more temporally. And it looks like it's in the internuclear layer mostly, with some also some hyper-reflective spots as well. And then here's the left eye. The vitreous is detached. It looks like there's a much larger amount of intraretinal edema and then some subretinal fluid as well.
So this is just showing the numbers for the
Thicknesses.
macular thickness.
Can I pause you for 1 second? We're getting a really crappy display. I'm gonna try to fix it. Just give me 1 minute. Still. It's the resolution. I gotta click on the second display to get the resolution. Okay. Yeah, but that's extended. No, can't get it to change the resolution. Hold on, almost done. Yeah. All right, I give up. All right, hold on. I'm gonna go back to where you were. I'm stuck. Hold on, I gotta duplicate the display. 60 seconds. So. All right, go ahead. Sorry, didn't work.
Is it showing the thickness map for everyone?
Yeah, it's showing everything. It's just the
Just blurry.
resolution on the TV is horrible here for some reason. I don't know what's up. I can't get it to adjust the resolution. Go ahead, sorry.
Let's see what you need to see.
And so, Grant, I'm not sure if I cut you off, but essentially just showing the average thickness. So the right eye central macular thickness is 359, and then the left it's 683.
So is this IR?
Fundus autofluorescence.
Oh, it's autofluorescence. Okay. So autofluorescence of the right eye, it looks like in the superior macula, there's some hyper and hypo autofluorescence. And then left eye, just some hypoautofluorescence in the central macula.
And then here the question was if there's a little bit of hyper autofluorescence by the disc. I can just go through some of the photos.
FA. It looks like there's some leakage in the superior mac in that same area. And then also in the central macula, kind of in a petaloid pattern.
Yep.
I disagree a little bit. Go back. So the superior lesion is sustained. And what you're seeing in the middle looks more like leakage of CME.
So the hyperfluorescence only expands in the center macula. That's fair. Okay, and then for the left eye.
Next question.
Very nice leakage in the center macula, and then maybe some little spots of surrounding staining as well.
Now, what about the nerve? The nerve's actually important in these cases.
Some nerve leakage too.
Right.
Okay, so summary, we have a 74-year-old male who had had cataract surgery 14 months ago with 12 months of recurrent blurred vision in the left eye, about 2063. Vision did improve with the use of Pred Forte and Prolenza, but the patient could not be tapered off the drops. So the main image findings in the left eye more so than the right. In the fundus photo, there was a blunted reflex, some hypopigmented spots within the fovea, mainly on the left. The OCT macula showed loss of foveal contour, retinal thickening, intraretinal hyporeflective cystoid spaces, and also some mild subretinal fluid. The left eye. The autofluorescence showed some areas of hyperautofluorescence in the central macula, and then in the left eye, specifically mild hyperautofluorescence adjacent to the optic nerve head. And the FA showed the hyperfluorescence with blurred borders in the central macula that did expand with time, consistent with leakage in the petaloid pattern in late frames. So do you have a differential?
Yeah, so if I remember correctly, he had cataract surgery not too long ago. So cystoid macular edema or like Irvine gas, probably on the top of the differential, but maybe some other causes might be diabetic macular edema. If he has like an occult CNVM, or if he had a small BRVO, that could also be other causes of his retinal edema.
Very good, Grant. Thanks. And then that's why the nerve's so important. So if you're really differentiating those, the first one, the nerve lights up, and the last three, it does not. So that's why looking at the macula is important, but looking at the nerve is important too.
So for the differential I listed here, I did it based off of leakage on FA versus no leakage on FA. So Grant mentioned a lot of the things on the left side, DME, vein occlusion, could also be related to uveitis, a tractional issue, dystrophic issue, and then medications, specifically latanoprost is one that's mentioned a lot. I also saw fingolimod and rosiglitazone as well. For the angiographically silent CME, juvenile retinoschisis, Goldman, Favre, Favre, I don't know how to say that. And then the classic meds to remember for this one is nicotinic acid, and then some of the chemotherapy agents, paclitaxel, docetaxel, vinblastine, and vinorelbine. Do not have leakage. Okay. So for Irvine gas syndrome, in terms of the pathophysiology, it's abnormal permeability of the parafoveal retinal capillaries, which usually results in pooling in the outer plexiform and Henle layers. This typically occurs about 6 to 10 weeks post-cataract extraction. On imaging, the two main ones to kind of mention are the OCT macula. This will show those intraretinal hyperreflective cystoid areas, may have subretinal fluid as well, and then diffuse retinal thickening. For gold standard testing, FA is still considered the gold standard, and you can see that petaloid pattern of fluorescein leakage with the late frames. In terms of treatment, this patient was already on the drop steroid and NSAID or Prolensa. And then if that does not help, you can consider periocular or intravitreal injections of different steroids. And then BCSC did mention you could also consider intravitreal ranibizumab, but I'm not sure how often that's ever done. Is that something anyone has done at your practice, Dr. Cohen?
Yeah, I don't like that. Yeah, I don't know why they put, it must be younger doctors writing it, but the anti-VEGFs generally stop leakage, but if it's for cystoid edema, they don't work very well, actually. It's an interesting thing. I have a number of patients, I'm trying to keep them together, that have wet AMD and don't respond well to anti-VEGFs. And actually, when you do the fluorescein, they probably have some uveitic. And so I don't think it works as well, but yeah, it does. But there's, if you have a glaucoma person, actually I have somebody coming in, it's an interesting option.
And then if you have any post-surgical complications, so if you have like vitreous adhesions, treatment would include a YAG vitreolysis or vitrectomy, or if you have any iris that's still kind of reposited in the wound, then you could do like release of the iris tissue in those particular cases. So for this patient, his vision did decline with CME. The patient was treated initially with drops, Pred Forte and Ketorolac QID, and did fine, but then had trouble with compliance of those using those drops. So he had 17 on Kenalog. The IOP did spike to 30. He failed a taper to QD, Pred Forte, Ketorolac, and now he's on BID dosing for Pred Forte and Ketorolac, and has since moved out of town. So here's a nice kind of summary of his entire course, which is a cool kind of comparison. So initially you can see on the upper left, when he first was referred, he was just on the drops, and then switched to Kenalog since it sounds like he wasn't very compliant with using the drops. Did have that IOP spike, so restarted drops, did quite well in the bottom right. And then tried to taper down to Q daily, but then at the bottom left here, you can see the SAMI came back quite a bit. Increased it back to BID, and then this kind of last photo here, I guess before he moved out of town, he was doing quite well on BID dosing. Okay.
Okay, go ahead, but I have some contributions to make when you're ready.
Yeah, go ahead.
Well, this was the first paper that Gass described fluorescein in.
Oh, interesting.
It was CME, and he pointed out the disc edema as part of it. In the differential, you should consider propionibactase in the capsule. I once got aggressive with that, and we basically enucleated the eye in the end because I stirred up. Oh, I released it from the capsule. He got fulminant and off the -4 before it was just like this, and so at that point, you know, with all this pus in the eye and the retina flapping in the breeze, I think I enucleated him. I can't remember. It was one of my last cases, but if you have a chronic P-acnes, maybe just treating the steroid is the appropriate thing.
Rather than doing what you
rather than getting aggressive like I did and losing the eye. So
it's so rare.
You have to, there's an old Jewish saying, right, Drucker? which is, it can always get worse.
Oh, yeah.
And I proved that.
All right, go ahead, Kim, thanks.
Okay, so I have some OCAP style questions since it's coming up for us. So accumulation of fluid in which of the retinal layers specified by letters in the photo accounts for the petaloid appearance of CME on FA.
So there's A, B, C, D, top to bottom.
Mhm. So
I
here's,
just don't, it's our resolutions.
here's B,
We're gonna
C,
have to call on somebody.
D.
We have some third years. We have Matthias and Kevin both here.
The outer plexiform layer, right? Which I couldn't tell there.
Yes. And I'm not sure if you can see the resolution, but I'll just tell you it's C. So plexiform, and then BCSC mentions layer of Henle as well as the two main areas. Perfect. And then the next question, 68-year-old patient underwent complicated cataract surgery 6 weeks ago. It was complicated by intra-op floppy iris syndrome and prolonged phacoenergy. His FA and OCT are consistent with CME. Which of the following would be the least recommended post-operatively for this patient's condition?
You want to do that, Colin or Madeline or Courtney? Or Grant?
Subconjunctivism.
Yeah, exactly. And again, the book mentions you can use intravitreal, but it's not something that I've ever seen. It doesn't sound like our retina surgeons today do that either. So yeah, it's the subconj is what they're pointing at. It should be intravitreal, and even still, that's not very common at all to do. Okay, then that is it.
Questions or discussion? That was very good. Thank you.